I want to introduce you now to the person that knows the data better than anyone else, who's been collecting the data now for 15 years. And Jim has worked the information. Jim Augustine is a member of the EDBA board, a member of the ACEP board, and is responsible for all the data that we have. And he will give you a run-through of this year's EDBA data report.
Good afternoon. And it's a pleasure to be here, and I have to really move fast so that at 4 o'clock in the afternoon, you're not bored to death by data presentation, right? Because next is just a little bit of a panel discussion, and then we get to go and have adult beverages. So what's really important in our industry, and has always been, is that we set the stage for our own future and for all of the people that have to follow behind us, because unfortunately, we have an industry that is very much attuned to a younger workforce. And so it is our responsibility to plan for the future of 150 million patient encounters a year, which is where we are in emergency medicine in the United States these days. 150 million patient encounters, which is typically the biggest touch of the hospital to its community. And in particular for high acuity centers, may have an even bigger reach in terms of what you define as a community. So what we have to have is the data that backs up what we talk about in the C-suite, and how important it is that we have an ability to plan for our future, which emergency medicine is widely known not to do. We are well known to complain about whatever it is that's going on today, and not to have a work plan for what's going to go on tomorrow. Currently, we have data sources that are getting a little more expansive. Nonetheless, they have to be very facile in how you're able to use them. The CDC has been doing data studies of the emergency department since 1992, which was 2 years before we had our first meeting with Bruce Janiak in 1994, the Benchmarking Alliance. The common issue at the time was the growing populations of Americans being seen in emergency departments. And in 1994, a common identification was when you hit 100 patients a day, the emergency department went to hell. The threshold to hell was 100 patients a day, or 40,000 volume per year. And so we pulled together a group of 40,000 emergency department leaders and said, how are we going to run these big shops? 100 a day with high acuity is just a miserable experience. And then we heard new words called diversion and rerouting, which we hadn't heard before in this country. And so in 1994, we set out to improve the work of leaders of 40,000 visit emergency departments. In 1995, the first published data from a 92 survey from the CDC came to be, and since that time we've been working collaboratively with the CDC to make sure that they can characterize emergency department visits while we characterize emergency department operations. A few other organizations have been studying ED visits, including American Hospital Association, which have an influence on what all of us do. And recently, AHRQ has gotten into the mix with a survey called HCUP. You'll see publications from that every once in a while. Right now, their focus is on mental health and its implications for the emergency department. And then you will see in the back, and Dr. Goyal is here, Pavan Goyal from ACEP, that ACEP has had to design an emergency department clinical data registry called CEDAR. And for emergency physicians, it is necessary for us to have a registry which functions in the long term very much like a tumor registry or a trauma registry in recording visits and then being able to provide a quality picture for emergency medicine practice, provide a background for us to get paid, and importantly then to look at some of the elements of the change in emergency department visits through upcoming years. So we have some data sources. The advisory board in 1995 wrote a document that still to this day is the process map for the emergency department. That document was called the Clockwork ED, 1995, and all of you should have an original copy of that document in your emergency department management office. The Clockwork ED provided the process map that still, 25-ish years later, is the process map for the emergency department and the extensions. The Healthcare Advisory Board, which is very influential in the C-suites, continues to say the ED is the hub of the enterprise. The ED is the hub of the enterprise. We should all incorporate those words into everything we do with the C-suite. There are two entrance doors in general to the hospital, labor and delivery and the emergency department. And typically you have a much greater influence on what goes on in your hospital. And the advisory board continues to say we serve as the hub of the healthcare enterprise and the central point in the community for healthcare access and the barometer for what's going on with healthcare in your community. And so accept that designation, copy this document as well, and begin to realize the future of your practice has to be created around data sources and your ability to provide ongoing plans for the C-suite to make good decisions about you. So you've heard about the origins of the Benchmarking Alliance, and Nick covered those. The first battle we got into came as a result of the CDC data. And so we had to learn about the use of federal data and how it applies to what we do in many community emergency departments. I told you already the Emergency Department Benchmarking Alliance is originally about 40,000 plus EDs, okay, who had a tendency to be a little higher acuity and higher volume than standard small emergency departments. So the first thing that happened, of course, was that the payers decided to punish the ED, where all bad people go, correct? All bad patients go to the emergency department. And so the CDC data, over-reflecting small, lower acuity EDs, said the average admission rate for emergency departments was 10% in the original data, 10% admission rate. 2 standard deviations away was a 15% admission rate. So how would the CDC data be used by payers to beat us up? Well, they said that means that any ED that admits over 15% is a bad ED. It probably has lousy physicians who don't know about making good admission decisions. They're probably lazy, and therefore we should punish them. And the original threat by a big name that is still in the market all these years later was any ED that admitted over 15% should be punished financially for their admissions. And so that big payer instituted a payment denial program or a payment reduction program. So we had to say, well, what does our data show? And began this process of getting to correct and uniform definitions and application of definitions and an ability to cohort hospitals so that we don't continue a very bad behavior, which is to say an ED is an ED, because they're not. And it's like you sitting here in a Renaissance and saying a hotel is a hotel. I notice most of you aren't staying at the Motel 6 down the street, and you do that for a very good reason. You want a different experience, a different level of safety, a different level of cleanliness for the beds that you sleep on at night, and the ability to stay away from the drug population that's going through a motel down the street. Get the picture? So we have the opportunity to differentiate emergency departments. And at the time, the Benchmarking Alliance average admission rate was about 22% of patients being seen in the ED. So we had to go to battle with Anthem and say, don't mischaracterize CDC data. Don't mischaracterize high volume, high acuity emergency departments with a whole nation's worth of emergency department visits. And let's find a way to cohort emergency departments. So that's where we began. So currently, 1,880 of you, 1,880 emergency departments are part of the Benchmarking Alliance. We have level 1 and 2s represented well. We have urban, suburban, rural characterizations. We have a great set of definitions, and Maya did a wonderful job today characterizing what we have to do every 4 years, which is pull the industry together in one room and say, update the definitions that we need to manage the industry. And then it's up to all of us to use those definitions and to come up with good comparatives so that we can represent the interests of rural hospitals seeing under 20,000, community hospitals seeing 40 to 60,000, and urban centers, level 1 trauma, high-level stroke centers, comprehensive stroke centers, et cetera, in the ways that they deserve to be characterized. So we initially looked at the data and said, you know, there's a break-off in operations in 20,000 volume cohorts. And for all of you who have worked in or lived through different emergency departments, you recognize a 20,000 visit ED operates very differently than a 40,000 visit, operates very different than an 80,000 visit. And for all of you who haven't done that, you should live through an experience where you're in a 30,000 volume, stable little cushy practice, and the hospital down the street closes. And you immediately bump from a 30,000 to a 50,000 visit ED, and half of your staff quit. Okay? We seem to run in 20,000 volume cohorts. Therefore, in 2006, when we set up the first performance measures, we said we will cohort our EDs in 20,000 volume increments. And then we began to collect the data, and the data, in fact, verifies that. That when you look at the different data sets, the performance of these EDs is very different. As we have grown in our field, what used to be a stressful experience in a 40,000 visit ED is now the average emergency department. And in this country, the average emergency department, if you run the numbers, is seeing about 44,000 patients a year. And we have 58 members of the Benchmarking Alliance that see over 100,000 volume a year. So you can see how these have been characterized and how we have emergency departments of varying sizes, which reflects patients per day. And for all of you in seasonal shops, you know the difference when you're in season or out of season and how the emergency department operates. In addition, we characterize EDs that see a lot of children, and we have over 80 pediatric serving emergency departments. We have over 200 adult serving emergency departments. And now we have 234 freestanding EDs that are part of our systems that the Benchmarking Alliance partners with. 234 EDs that see 3.5 million patients. Okay? They're very different animals, as you would expect, than their full-service hospitals attached to inpatient beds. So those are the cohorts as they present in the emergency department. So here we are, 1810 with 78 million, 234 and 3.5 million. Our volumes over the last 3 years have been relatively stable. Today at home in your shop, it's, what day of the week is it? It's Monday. Are your staff members having a good day today at home? Nah, and probably a lot of you are problem solving because it's Monday and the place always goes down the tubes on Monday. So you can look at your average volumes, but no, on Monday it is worse. And that the acuity rates are higher than expected. For many of you, that began about 6 o'clock on Sunday evening. So they're about 18 hours into their push. And Tuesday, somewhere at around noon, is when things begin to go down a little bit in terms of acuity and volumes. The nation is in the midst of a battle about how we're going to pay for the health system. And the insurers have mischaracterized the ED as the site of all evil, okay? And come up with this idea about surprise bills for patients when in fact the issue is it's surprise insurance company for our patients, insurance coverage for our patients. And many of you are involved in educating legislators and regulators that we've been seeing these people all these years. They keep getting sicker. They don't have other sites of care. It's very reasonable for them to come to the ED. If you look at the Minute Clinic down the street, it's full. Everybody who can goes there. There's an urgent care the other way. The low acuity stuff goes there. We're left with all the sick people. And we take care of them very, very well. and our processing times are very, very low. And they're sick enough that 17, 18% of them need to be admitted. 17 or 8% of them arrive in an ambulance gurney. Those are sick people. And what they expect is that their payer will pay for their coverage when they come to the emergency department. And we wish that we could open up lots and lots of primary care spaces and have people know their disease and know what is causing their chest pain, belly pain, headache, shortness of breath today, and be able to make correct decisions. But unfortunately, we're not in that circumstance. And a lot of people don't understand why their chest hurts, or why they're short of breath, or why they're running a fever. And they call their primary care physician, or call and ask a nurse. And the response to that request is, go to the emergency department. And sometimes you have to document that to help the patient, because you know later on their payer is going to deny. If somewhere down the line their ultimate diagnosis turns out not to be an immediate life threat. In some cases, even immediate life threats are turned down, denied by the insurance company. So, with that in mind, recognize we still have communities who have people who want to see you. Our flow is very, very good, as you will see here. And actually our door to provider time, both in the CDC data and in the benchmarking alliance data, is under 30 minutes. So the median time from door to provider, 27 minutes in our data. Mental health, easy to manage in your community, becoming a terrible burden, and it's stopping up many of our emergency departments and occupying beds. And the opiate and other substance use problems decreasing in your communities? No. And so we have a double burden of dealing with some difficult to manage patients and sometimes physically difficult to manage. So you have half of the active ED staff who are working today trying to take care of a department full of patients who are wrestling with somebody in one of the rooms. We get far too many of our providers injured in those encounters, and we lose, very frankly, way too many nurses who have been beat up one too many times in the ED, and they head to PACU, which is a whole lot simpler a place to work than the emergency department. A dreadful, dreadful, dreadful problem for the emergency department. Okay. The ED is the front door, so you're going to hear this 22 times. And the innovation message from my talk is prepare and work a lot on the admitted patients. They're a significant part of our responsibility to continue to be the front door to the hospital. The 2017 data across all EDs says 69% of people arriving in an inpatient bed get processed through the door that says emergency department. They get processed in very efficiently, get their diagnostics done, get their treatment initiated, and then get placed upstairs. Another 30%, 31% come in a different door. In many places, it's the labor and delivery door. But in most community hospitals, there's relatively little direct admit and relatively little transfer from another institution. For those of you who work in high acuity places with high acuity services, you will see relatively less percentage of admissions because there's an alternate pathway, a helicopter onto the roof, and then down in your cath lab or down into your operating rooms, etc. But for most of us, 69% of inpatients arrive through the ED. Does that have dramatic financial implications for your hospital? If they shut that door down, they would lose hundreds of millions of dollars in revenue. And although your CFO may say the margin on a patient who comes in for elective surgery is higher than the margin of patients that come in through the emergency department, can they keep the doors open? Can they keep the lights on if 70% of their inpatients were shut off? I say no. All right. So, how do EDs perform? Well, here's my estimate in looking at the data. An under 20,000 visit ED, you can't screw up no matter what you try to do. Okay? Under 20,000, under 55 patients a day, You might have the worst ED leader, who typically is the best doc and the best nurse in the mix, and there's your turn to be the nurse manager, it's your turn to be the physician director, and they may rotate a little bit. You can't screw up under 20,000. Between 20 and 40,000, it's really hard to screw it up. Most of those places still run on their own. Starting at 20,000, you have to add double coverage. You have to add some triage function. You have to get some clerking functions covered. You'll have to have double providers during the key times of the day. Under 40,000, it's still very difficult to mess up. Where we're doing CPR on ED leaders now is the 60 to 100,000 volume band. 60 to 100,000 volume. And it looks like at 100,000, you watch EDs in our database creep up the volume ranks, and they're struggling between 60 and 100. And at 100, all of a sudden, all their performance metrics improve. Their nurse staffing ratios go down. And it's like the CEO at 100,000 visits comes down to the ED and says, "You've made it through your stress test. It's time to resource you up." Okay, so at 300 patients a day, for many of you should know, at 300 patients a day is when the CEO is taught at CEO school. You need to go down to the emergency department and give them what they need. Okay? But getting there is tough. Getting there is tough, and the 60 to 100,000 is the difficult to manage emergency departments in this country. All right, CDC, again, doing their data, but they are really delayed. So I'm expecting in the next month they will release their 2016 data. But looking at the data since 1992, we're seeing 2% more patients per year. They are sick. They're not hurt. In my start in emergency medicine 35 years ago, the chart rack was 50% injured, 50% ill. 50% injured, 50% ill. You tell me what's in the chart rack at home right now. Mid-afternoon on Monday, what's the chart rack look like? Laceration, sprained ankle, back pain? What's in the chart rack? Number one is belly pain. Number one is belly pain. In any of the surveys, including the CDC, the number one single complaint is abdominal pain. And your provider's picking up that chart at 4 o'clock in the afternoon on Monday going, "Oh, God, I want to get out here in an hour. It's not this one." So they go to chart 2. What is chart 2? Chest pain. Number 3, short of breath. Number 4, altered mental status, weak and dizzy. Okay? They're looking for something they can get done before they leave shift, and it ain't there in the chart rack. Okay? And that's the way it is. So the CDC says 29.5% is injured. We have a growing problem with then old, high acuity, complex medical issues coming in the emergency department. AHRQ, by the way, says the same thing. Here is our volume numbers since, and I cut it off at the bottom there, that's 1958 is when federal agencies began collecting data on emergency department visits. And I say by the late 80s, the federal government and the CDC said, a lot of people going in those EDs. And at the time, the volume was 65 million patients. This year, we're at 150 million. Okay, so you can do the multiples there. And that growth line keeps going up. And as a matter of fact, it's probably a little higher than that, but the CDC decided not to collect data on freestanding emergency departments. A couple years ago, an administration said, we think ED visits are bad, and so we want the CDC to report them going down. As a matter of fact, they wouldn't let the office release the data for a couple of years because they didn't like the results. The office has been underfunded because they don't like the results. Why can't you make those numbers go down? Now, why do we have freestanding EDs? Because the motherships can't suddenly move and can't cover the growing metro areas that we have. And so very appropriately, the inpatient's hard enough to manage. Let's keep that at one site. Keeping the specialists on call is hard, right? So let's keep that at the mothership. But let's put community-based care centers And if we leave ED on, as you heard earlier and you'll see later, freestanding ED leads to higher reimbursement, higher charges and higher reimbursement. And it's got the logo of the mothership, okay? And for many metro areas, that's fabulous use of resources. Rather than building a whole new hospital with inpatient beds and trying to fill the services in a suburban shop, let's just use that. It's a lot easier to keep the mothership and then to build freestanding EDs, and then the appropriate service package of imaging and maybe some outpatient surgery, et cetera, built into those buildings. So we have a lot more freestanding EDs. They are built specifically to offload the mothership. And if freestandings weren't there, that 3.5 million patients in our survey would be going to the motherships. They should be included in CDC data, but right now they're not. Okay? We have predictable flow. And the numbers you have to keep in your head are that for 1,000 people in your community in any given year, there are 450 ED visits. 450 per 1,000 is the utilization of emergency departments in the United States. It happens to match Canadian numbers, even though they have a different structure to their health system. We're at 450 per 1,000, and so are they. Of the 450, 83% walk in, 17% arrive by EMS, and then across all EDs, we have a predictable disposition, which is 79%, almost 80% treat and release, 17% admit, 2% transfer, 2% leave before treatment complete. You need to know these numbers for your community and, frankly, work with other EDs so that you can predict these numbers going into the future. There's nothing that would tell us that ED volumes are going to decrease. I'm sorry. I've read all of the papers that say ED volumes are supposed to go down, and until our demographics change and we quit manufacturing old people, volumes are not going down in the ED. They're not going down in the emergency department. And so that's the plan ahead. I got news for you. If you want to know how to plan ahead, go to labor and delivery and ask them if they have diversion or rerouting. Ask them if patients are allowed to receive care in their hallways. Ask them if patients are supposed to be moved from place to place to place within labor and delivery, and see what the answer is. And they'll say, you guys are crazy. I've seen what you do down there, and it's wrong, and it's not safe, and I don't like to go down there because I don't like what you do. A lady comes in up here and says, I'm going to have a baby. She gets put in a room, and she stays there until we deliver her baby, or there's a crisis, and then we have this little resuscitation area, just like we do. Okay? Otherwise, we send the family there, we send the phone calls there, she labors there, she delivers there, we deliver a nice package coming out the back, and we don't divert or reroute anybody. And why does that happen? Because L&D leaders across your community plan ahead and know predictably seasonality of delivering babies. They know about the population trends in the community, and together they say we need this number of beds to deliver this number of babies that's predictable in our future. We should have just as much smarts in running the ED, and we should just consider it unacceptable to deliver care in the hallways, which we do. Are they doing that at home today at your shop? Anybody who doesn't have their care going on in the hallways at home? On a Monday, 3 o'clock in the winter, I congratulate you. There's an innovation. Oh, okay. Okay. Yeah. Okay. For those of you, people will the C-suite will push back against that kind of planning, and they do, and they say that's because ED volumes are going to go down. We know that, okay? And for some reason, care in the hallway is acceptable. And we got to be much smarter in how we do this. All right, run in some data. Big shops see sicker patients. Adult shops see sicker patients than peds. Freestanding EDs see less acuity. Big surprise? No surprises there. So we have lots and lots of charts that have a very similar pattern when you look at the different types of emergency departments. Be very careful in ever presenting any data that is not specific to your cohort, okay? So I can talk a little bit about average use of EKGs, average use of CT scans, average ambulance arrivals, et cetera. But if you're practicing in a 100,000 volume trauma center, stroke center, cardiac center, your data is way different than average. And so pick your cohort, pick it out of this list, do the appropriate comparisons. Under 18, if more old people are coming to the ED, that means less pediatrics is coming in. Great success story. More immunizations, more pediatric urgent care, more healthy kids in our communities. And in some metro areas, they have a children's hospital, which does a great job. I practice in a couple places. I couldn't live without Children's Healthcare of Atlanta. They do a fabulous and very responsible job. Never go on diversion or rerouting. Consider it their responsibility. Under age 18 in our community, you're sick, you're hurt, you come to our place. We'll take care of you. They don't buckle when it's RSV season or rota season or norovirus season, and they move patients very, very quickly. Thank you to those of you who run pediatric serving emergency departments. The rest of you in community hospitals should continue to expect less pediatrics in your mix going into the future. Arriving in an ambulance, much more prevalent in high volume, high acuity shops. Obviously much, much, much less in pediatric serving shops. Okay? Very important. And innovation is to take good care of the paramedics. They bring good patients to you that result in admissions, that result in good outcomes and in a good reputation for your community. Think of it another way. It's Friday night. They have a patient who's not very nice, doesn't smell very good, and they know it's going to be real trouble for the emergency department staff. Where are they going to take the patient? To whichever hospital they don't like. Okay? So a really important reason to be really good with EMS is they also control the destination for people who are not so nice in the ED. Lengths of stay, predictably higher in higher volume shops than in lower volume shops, and adult serving shops rather than pediatric shops. Don't use average numbers for planning. Use the numbers specific to your cohort. Median length of stay for all patients. Now, this relatively shows a bigger swing than actually it is. I think we need to plan in our standard community emergency departments for a 3-hour length of stay, because we have proven over the last 15 years that's where we are. A 3-hour length of stay is typical for the all-patient cohort categorization of emergency departments. This slide was for all patients. Next slide is for all patients. Okay? This goes through the years, 2004 through 2017. It is for all patients, 3 hours. Door to provider, less than 30 minutes. Faster in smaller volume emergency departments. Door to provider and left before treatment complete. Do you think there is a relationship there? Shorter door to providers equals less people walk away. A very important parameter. Door to provider, academic versus community. We do much better in the community setting with seeing patients, so we can slice our data in different ways. In the academic centers, a little challenging sometimes getting patients to the provider. Left before treatment complete. So here's the big number, and as was mentioned this morning, this is the only fair way to characterize EDs. We can't parse them out and eliminate some of the categories, so we insist when people give us their data that they include all of those categories and don't say, oh, we don't include AMAs, oh, we don't include elopes. That's a good way to cheat. And you cheat each other, and we cheat our overall ratios. Not a fair thing to do. You do realize, looking at this data, over 100,000, still tough keeping people in the department. Over the years, we have roller coastered a little bit. So this is the data from 2004 through 2017. If you recall, 2006, 7, 8 is when we had some really bad cases in the press. In California and New York and Illinois, we had very, very public cases of people dying in the waiting room, filmed, and where county prosecutors contemplated manslaughter charges against triage staff members. Fair? People came in without a fatal problem, and you put them out there to die. The prosecutors contemplated manslaughter charges. That is not something that we want in the industry, and is not the image we want in the industry. People began to take it very seriously and develop the programs that Sherry and others have talked about today, which is moving the front end through much more quickly and getting to the point where people aren't dying in the waiting rooms and they're getting back to the providers. So you plug them in quicker, you get them out quicker. That makes a lot of sense from physics. And so we worked very hard in 2009, 2010, working those ratios down. They're creeping back up a little bit, and something that as volumes continue to grow and as the compress gets worse and worse with evening flows is very important. The most important predictor of walkaway rate, by the way, is boarding times. Okay? So another innovation is you've got to work on boarding times or you cannot influence your walkaway rates. Volumes also help predict left before treatment complete. So this is, length of stay does. And so the overall length of stay, a little scattergram here to show you how you can use some of our data in another form. Team triage is the active triage process involving a physician or APP in the front end process. And it's now being used in a quarter of EDs over 40,000 volume. Probably an efficient use of resources, one that my group uses a lot of. And the physician in the front is dedicated towards getting the person plugged into both diagnostics and treatment. Very important that you recognize what bringing an APP or physician to the front end does. We can write a lot of standing orders to get diagnostics started through nursing, right? Get an EKG, get a chest x-ray, get an x-ray of an extremity. If you add the treatment element, which comes with physicians, pain control, local anesthesia, IV fluids, nausea medicines, etc., you very much influence the total length of stay for the patient, and you get to the disposition time much more quickly when you have initiated treatment early. And so that is the secret sauce to adding a provider to the intake process. And if you move them to the back more quickly, then lab and lock gets done, treatment gets initiated, diagnostic gets initiated, walkaway rates go down, good things begin to happen. Diagnostic stuff. So we'll talk about EKGs, MRIs, CTs, and ultrasounds. If you're in a high-volume shop with higher acuity patients, diagnostic testing gets used a lot more. EKGs have gone up, and the funny story, which I don't have time to tell, is the patients won't read a textbook anymore and know that MIs only present with chest pain. Now what do MIs present with? Any complaint from here to here. And frequently it's weak and dizzy. The patients don't read a textbook. You have to do EKGs a whole lot more. And an innovation is get the EKG machine to the front, allow techs and nurses to be able to initiate EKG, and get the EKGs initiated within the 10-minute quality mark that we have for EKGs. But it results in that machine being used a whole lot more than it used to be. CTs. We have maxed out at CTs, but you will notice if you look at the CDC data that they report a number 16, and in the benchmarking alliance we report a much higher number, 22, 23, 24. Why is that? The CDC data is only looking at the percent of patients who get a CT scan, not the number of procedures done. If you go home today and ask how many patients go over from your ED to the CT scan machine, nobody has that number. The only number they know is how many procedures are ordered out of the ED. And as all of you know, a kidney stone scan, which is one checkbox in the electronic health record, how many procedures are associated with a kidney stone scan? At least two. At least two. Okay? So it's very important that you use the comparatives that are appropriate for you, and the CDC data does not have the correct comparatives. So they measure the percent of patients that had a diagnostic test done. We measure the number of billed procedures that are in the system. And here's where we are in CTs. Just so you know, we are back at a very stable number. But if we have kind of flattened the growth in CT, what is going up in terms of imaging in the ED? MRI scans and ultrasounds, which are both still on an upward trajectory in use in the ED. Okay, I gave you a bunch of data, but if you went home today and talked about benchmarking alliance data and how it relates to your emergency department, your staff is going to get glazed over. A strong recommendation and an innovation is you develop a piece of paper that looks something like this, that talks about the day that we have in our average an average day that we have in our emergency department. And an average day is 140, although 3 want to leave. 23 of them will get admitted, which is 26% of the patients in the main ED, very few of the patients that go over in the fast track. 30 times a day that you're going to need to pull out the EKG machine. More on Mondays. Quit bitching if you're working on Mondays. You have to pull the EKG machine out more. You have to wheel more patients upstairs. You have to start more IVs. You have to draw more labs. It's Monday. It's predictable, okay? And so this is what makes a difference to your staff. And then we got epic numbers from RED. 22% of all orders entered into the hospital's order entry system are in the emergency department. That's a really significant number. And the average is 8 orders per patient. And so an important number came to us when we did the Epic install. All right, a couple more quick numbers. CEO school says you need 1 bed for every 2,000 visits. In CEO school, they all learned that. So your 50,000 EDs should work just fine with 25 beds. And it's completely wrong. It is completely wrong. The correct ratio is, again, volume and acuity dependent. If you have high adult patient ratios, if you have longer boarding times, you need at least 1 bed per 1,200 ED visits. A PED center can move the little ones through much more quickly. Inpatients, very important. And the Evolving Axis has EDs and hospitalist physicians working together very, very closely. I mentioned to you the main entry door to an inpatient bed comes through the emergency department. About 70% across the nation of inpatients arrive through the ED. That has gone up over the years. And in my career, it's more than doubled in terms of the ratio. Of the patients who arrive in the emergency department, a very reliable number across this nation is about 17% of patients arriving in the ED will need admission. About 80%, again, get treated and released. About 2% get transferred. About 2% leave before treatment complete. If you're in a small emergency department, small volume, more rural, lack of coverage by specialists oftentimes results in you having to transfer patients to the mothership hospitals. Admissions go along with ambulance arrival rates. We did a little work on staffing, and the important numbers that you need to understand is the APP ratio of professional staffing is going up, and it's going up very dramatically in the last 5 years. We, in many places, are seeing more APP hours than we're seeing physician hours in the emergency department. What has been very stable, and it's been covered earlier today and will be covered, nursing ratios are very predictable at 0.6 patients per hour for the RN staffing. What is very irregular is tech staffing. And clerks are disappearing at a rapid rate from emergency departments as we move towards electronic health records. NAHAMSIS talks about the types of patients we're seeing. And I want you to be aware, Medicaid just overtook commercials as the #1 patient insurer coming to EDs in this country. Medicaid, now across the nation, the #1 payer for patients coming to the emergency department, but many Medicaid patients are treated and released from the ED, so they represent much less in terms of the stream of patients going upstairs. The stream of patients going upstairs, older, sicker, medical patients with multi-system disease heading up into the inpatient units. I want to do just one little cost number because I'm at time here. Sherry, am I okay? Just a minute? Okay. I was a little worried about what's going on in the charge world in our nation and what kind of feedback we're getting from the communities about our emergency department charges. So there is a very good database, and it's based in Florida, where I happen to live. So this database records emergency department visits in the state of Florida, which is old, sicker medical patients as a characterization. Nonetheless, we look at those volumes going up. And then they characterized the charges for patients seen and discharged from the emergency department, and for those seen in freestanding emergency departments. And if you will look at the last 2 years that data is available, they don't have 18 data yet. In 2016, the average charge for a patient seen in the ED in Florida and released was $5,612. A year later, it was up to $6,284. And for a freestanding emergency department, a hospital-based freestanding, charges of $4,4200. If you look at the charges through the years, we are going up at a very, very rapid rate. And it has to result in some kickback in the media and from patients and from payers. And so I want you all to be aware the average charge coming out of our departments is $2,000, $3,000, $4,000, an additional physician bill of $5,000, $8,000, $1,000. And that is what we have to be accountable to as we go through the years. The financial implications of the institution to the emergency department have numbers like this. A 50,000 visit emergency department has a hospital revenue implication of $101 million. That is the contribution ratio for your admitted patients plus the direct revenue, not charges, the revenue that comes in for people seen in the ED. It is $101 million. And in another very similar calculation, if you're on diversion for an hour, it just costs the hospital at least $6,000. That's the number you need to keep in your head when it comes to staffing and staffing during crisis times and going on diversion. Our path forward in the ED, more patients are coming to the emergency department. They're older, they're sicker, they're more mental health and chemical abuse, and we need solutions and innovations in those areas. We also are responsible for a big flow of admissions going upstairs, and we have to do it very efficiently with dramatic financial implications for the hospital. We are also responsible for disasters, and it is very important that your ED be prepared for the next active shooter, bombs going off, etc. We have wonderful stories when we are prepared and handle those very well, and it's very difficult in communities where that process has not gone well. It's our responsibility to be prepared for those and to work very well with our community resources. And finally, it is our responsibility to train the future leaders who are going to take over our jobs and continue this process of seeing 2% more patients per year. And the story we have to build is about the quality and the plans for the future of unscheduled care practice in this country. I thank you for the opportunity, and I thank you for what you do every day. And I think we're going to break now and do a panel discussion, and I'll take questions then. Thank you.